time out tonight to come and attend our webinar discussing overactive bladder and solutions to bladder control issues. My name is John Lynam. I'm a local urologist here working over in Oxford and in Leesburg. And we have a PowerPoint put together just to at least touch on all the different aspects and topics of overactive bladder, what that means, urge incontinence, stress incontinence, and as well as some treatment options for you all. Assuming because you signed up and made time to be here, there's at least some interest in the topic. And my goal for tonight is at least touch on different areas, and if things resonate, things make sense, you want to perhaps look more into different solutions and options, be happy to talk with you guys one-on-one in the office. So we will get started. So first of all, my name is John Lynam. I grew up in New York, did my undergraduate at Stony Brook in New York, was down at University of Miami for my pre-med. I went to medical school out in LA. I did my residency in Chicago, fellowship at Pittsburgh. I studied stone disease and minimally invasive surgery. And over the last couple of years, I just became a lot more interested in overactive bladder and voiding dysfunction. I think as I got older, as I saw my parents get older, as I saw my relatives get older, I noticed people with urgency, frequency, incontinence, and really came to appreciate the issues, sometimes even the social embarrassment that this causes, and just really felt that if I could do something to alleviate that for people and make people's quality of life better, it just seemed like something that really appealed to me, and I just looked further into. And I've been down here at AUI in Oxford for a little over a year and a half now, and very thankful in the sense that AUI was very supportive of my overactive bladder interest, and they've definitely encouraged me, pushed me, and more importantly, supported me in trying to build up a practice that's more around overactive bladder and extending my knowledge and ability to help to you all in the local community here. Special interest I have is men's health, women's health, overactive bladder, and stone disease, like I said above. My main office is in Oxford and Ocala. And we have an office in Leesburg right next to the hospital as well. So let's just start with some basics. How does the urinary system work? So in general, urine is made up in the kidneys. It flows down the ureters into the bladder, and then the bladder squeezes and the urine leaves. Again, just kind of very basic. In order for that bladder to squeeze, the best way to think of the bladder is just like a big hollow sac. And there's a muscle that wraps around the bladder called the detrusor muscle. That muscle squeezes, and that enables the bladder to empty and create that urinary stream and let you void and feel relief. So all these, the kidneys, the ureters, the bladder, the detrusor muscle, all these things work in unison in order to create the urine, pass the urine, and then ultimately allow the excretion of urine. Everything needs to work together like a well-oiled machine. A lot of us like to think of ourselves more as glorified plumbers, so it's just some fancy plumbing that we do. So let's talk about some bladder control problems. What happens when that system, when that well-oiled machine isn't working so well? What can go wrong? Well, from a bladder perspective, from a urinary perspective, there's overactive bladder, and we'll get into exactly what that means. And there's also urinary incontinence. From an incontinence perspective, there's three main types that we talk about. There's stress incontinence, involuntary loss of urine with coughing, laughing, and sneezing. There's urge incontinence. I need to go to the bathroom. I can't possibly get to the bathroom fast enough. I have about 3 seconds to get there, or I'm going to wet myself, which again can just be very embarrassing and frustrating. And there's overflow incontinence. My bladder just gets so full that my bladder just unable to empty. Excuse me, my allergies are killing me. Apologies. So each have similar symptoms, and they can each affect the quality of life, but there's differences why they occur and how they're treated. So just to get a little bit of statistics, get a little bit of an understanding of what the prevalence is, how common is this out there? How often do we see this at work? How often do I see this in the office? And statistically, they say about 50 million people in the United States suffer from overactive bladder in varying degrees of severity. And about a quarter to a third of people in the US suffer from some form of incontinence as well. And, I think it's important to realize that this is a lot more prevalent than people realize. And I think in the last 10, 15 years or so, it's become I think it's become more acceptable. It's more to the forefront of talking about, hey, you know what, this isn't working right. This is bothering me. How can I be the best person I can be? How can I have my best quality of life? And I think for a long time that people just suffered in silence because people were embarrassed or we didn't have the ability to treat these things well. Nobody talked about these things. We wore pads, we did things, we brought changes of clothes. Maybe we avoided certain situations, maybe we avoided social situations due to fear of embarrassment. And thankfully, today, in this day and age, there's plenty of things that we can do to enable you to have a relatively happy life, unimpinged, and hopefully less worrisome. Let's first start with overactive bladder. What is overactive bladder? A sudden uncontrolled need or urge to urinate. Overactive bladder is the name of a group of urinary symptoms. It is not a disease. So it's just more of a descriptive term of different symptoms that people have. What are indications of overactive bladder? Bladder can't hold the urine normally. Say you have that urgency frequency. Say you have sudden strong urges to urinate that you cannot control. Again, that fear of leakage or that overwhelming fear that you're not going to make it to the bathroom in time. I go out to the mall. I know where every bathroom is. I go to a sporting event. I don't drink anything for 3 hours before. I don't dare drink a beer or anything or soda at the game. I'll never make it to the bathroom in time. So are you making lifestyle changes in order to avoid a potentially embarrassing or uncomfortable situation? People that visit the restroom multiple times a day. Usually, on average, I tell my patients urination every 2 to 3 hours keeps that bladder nice and empty, helps minimize infection, keeps us to be happy young boys and girls. I see some patients in the office that are avoiding every 10, 15 minutes. And although avoiding that often, never really feel that sense of relief, never feel that sense of my bladder is empty and I could go back to doing my regular things. It just is persistent feeling of pressure, urgency, frequency without ever having that satisfaction of and relief. Accidental leakage, if you don't get to the bathroom quickly enough, you have 2.5 minutes, and God forbid you have to wait in line and someone's ahead of you. And then people just end up leaking on their own clothing because they're just not able to control that flow of urine. On the flip side, maybe have trouble urinating. You have that urgency frequency, you run to the bathroom, and then you're not able to start your stream. I have to go, I'm there. Now I can't go. Uh, we talk about nocturia. Nocturia meaning getting up at night from your sleep to use the bathroom. On average, getting up, say 2 times a night, maybe 3 times a night, I'd say is relatively normal. There's people getting up 4, 5, 6 times a night. There's people getting up hourly. Again, just kind of disruptive sleep patterns makes for tired mornings and kind of cranky young boys and girls. And the things we could do to kind of minimize that as well. A good night's sleep, wake up in the morning at least refreshed and don't feel like the bear that wasn't able to sleep all winter. Moving on to incontinence. What is incontinence? Incontinence is the inability to control your bladder, which can present in 3 different ways. First and foremost, not in any order of importance, is stress incontinence. So coughing, laughing, sneezing, anything that exerts pressure on your belly that pushes on that bladder may cause small spurts of urine, may cause complete evacuation of the bladder. So we said, yeah, coughing, sneezing, heavy lifting, anything strenuous, shifting your body weight, even sexual intercourse, anything that distracts you from holding those muscles or anything requires any kind of vigorous activity can cause this involuntary and often embarrassing loss of urine. And unfortunately, people really have no control over it. People with stress urge incontinence, I'm sure would love nothing more than be able to hold their urine and not leak. Then there's just plain urge incontinence. I have strong sudden urges to urinate. That bladder squeezes, spasms uncontrollably, just severe bladder pressure, inability to control that urge, and just involuntary loss of urine. More common in women than men, especially women that have had vaginal deliveries. Sometimes those muscles down below get a little bit stretched out and they just don't squeeze and hold as well. Again, of no fault of the person suffering, but it's a sad reality for a lot of our childbearing women. There's also overflow incontinence, leaking or dribbling urine because your bladder gets too full. I say on average, the bladder could hold about a half a liter of urine and you'd be relatively comfortable. There's some people for different reasons, be it neurologic or other issues, that bladder just overfills. And once it gets so overfull, You just leak out little bits of urine, but never really empty. So you just stay over full. The best way I could picture provide a visualization for you. Picture a glass of water, and you fill that glass of water to the rim. Once that water is full, if you're pouring more water in it, that water that just spills over because the glass is full, that's your overflow incontinence. Your bladder's like that glass, and once it's so full, it literally can't hold anymore. So the urine that you're putting out is just that excess urine that absolutely has no room to stay inside the bladder. What causes these bladder control problems? So, like we touched on before, when you urinate, your detrusor muscle, which is the muscle that wraps around the bladder, contracts and physically pushes the urine out of the bladder. Afterwards, it then relaxes and allows your bladder to fill again. So it kind of squeezes it like an accordion. So your detrusor muscle around the bladder squeezes, causes emptying, relaxes, and the bladder refills again. It kind of goes back and forth, kind of like an accordion. Anything that happens or weakens that detrusor muscle can cause problems with bladder control. So any damages, any injuries, be it surgical, be it trauma, sometimes even medications, or chronicity of being over full can certainly interfere with that bladder control. From a medical perspective, bladder cancer, swelling and inflammation, even stones can weaken that detrusor muscle and make things less than optimum. Diabetes, if not well controlled, as we know, diabetes can affect all parts of the body, and urology is not excluded from that. If the diabetes is not well controlled, your muscles become flaccid, muscles become weak. You just don't have that same control that you used to have. You may even lose sensation. So you have loss of sensation, and then you have loss of strength and control as well. So it could be a dual hit factor with diabetes. Sometimes our gentlemen out there with enlarged prostates, that prostate basically sits in front of the bladder. When the bladder squeezes, the urine passes through the prostate and exits through the urethra and the penis. If that prostate is enlarged and it blocks, that bladder's pushing against the smaller opening, and unfortunately the urine can't pass, the bladder gets backed up and that bladder gets over full, like we touched on earlier too. Neurological issues, spinal issues such as herniated discs, spinal cord injuries, back surgeries. In our spinal cord, that's where our bladder muscles and nerves are. The muscles are innervated by the nerves through that spinal cord. Any kind of injuries in those areas too can sometimes impinge or limit the relay or the conversation that takes place between the brain and the bladder via that spinal column and via those spinal nerves. Other causes of bladder control problems, different medications, alcohol, caffeine. They can dull nerves, impede signal. They could slow down the signal. They could sometimes create false signals and then cause confusion between the communication with the bladder and the brain. Parkinson's disease, Alzheimer's disease, multiple sclerosis, any of these neurological disorders can also cause a breakdown in the communication between the brain and the bladder. The bladder can maybe sense things that aren't going on or become oversensitive or sometimes even undersensitive. Pregnancy and childbirth, as we know, ladies out there that have had children in the past, that baby sitting on the belly is kind of pushing on that bladder may cause some urgency, may cause some frequency, on top of the myriad of other things that you're experiencing. Radiation therapy in the pelvis too. Any kind of radiation to that bladder tissue may alter the function, may alter the sensation, may even alter just the way that the bladder is able to generate force and to be able to empty. Any surgeries in the pelvic region as well could physically impede the functioning of the bladder, and those nerves that we talked about earlier also are located in that area. If nerves get impinged or damaged during pelvic surgery, that could also change the way you control your bladder and able to void. Urinary tract infection, for those of us out there that have had infections before, knock wood, I have not, but I've seen plenty of young ladies and gentlemen with urinary tract infections in the past with urgency, frequency, just excruciating stabbing pain, pressure. And again, looking back how we spoke about earlier, just never had that sense of relief after urinating. Some of our ladies, they're also with a pelvic organ prolapse. Sometimes for our ladies, that bladder will drop down. Sometimes the uterus drops down and exerts pressure on the bladder. So there's just different physical things that could go on as we get older also that may play into this. So that begets the next question. How do we diagnose bladder control issues? how can we just get a handle? How do we quantify what we're seeing and the severity of what these issues are? Personally, first and foremost, when I sit and I'm able to sit and talk with a new patient or even an existing patient, and we want to talk about their severity, I think it's more important subjectively to hear what my patient has to say. How much is this interfering with your life? What are you changing in your life because of your symptoms? Is it stopping you from doing things? Is it making you hesitant to do things? How inconvenient is this for you? But going through the list here, there's different diagnostic tests that we could do. But just like to emphasize, at least personally, I think it's more important that we talk one on one with our patients and you tell me how severe are these problems for you? How life altering are they? How inconvenient are they? And some people don't mind them at all, and other people just find them completely debilitating. So it definitely runs the gamut. But I think that's the subjective component of your symptoms are important and valid. All right. So different tests that we could do. We do a urinary stress test. And what we do is we put you like in a frog-leg position, have you bear down and cough. And with that coughing, with that increased abdominal pressure, do you leak? Do we see a spurt of urine? Do we see leakage that's involuntary? There's testing that we do called urodynamics. The best way to explain urodynamics to people is kind of like an EKG for your heart. That urodynamics just tells us the overall health of the bladder. How well is that bladder receiving information? How well are you sensing what the bladder is feeling? And then when your brain's telling the bladder, hey, it's time that we need to go urinate, how well is that bladder responding to the messages getting from the brain? And we measure different pressures that are created and interpreted and your sensations of fullness. And it's just an overall bigger picture wise of how's the brain bladder communication and how's the overall function. Relatively painless in nature. It takes about a half an hour to do just because there's just various aspects. We look at nothing uncomfortable, nothing painful. There's also cystoscopy. We do those in our surgery center in Oxford. And basically what this is a big fancy word for a small little flexible camera. And we take a look inside the bladder under direct vision. We look inside the bladder, we make sure that urethra, which is the tube that connects the bladder to the outside world that the urine passes through when you urinate, make sure that urethra is nice and open, make sure there's no narrowing, make sure there's no blockage. And then we pass and look inside the bladder and make sure the inside of the bladder lining looks okay. Are there are there stones in the bladder? Are there masses in the bladder? Is there inflammation? Is there anything that's physically causing the urgency, frequency, the symptoms that you're having? So we just do a physical evaluation of the inside. A lot of people ask if we have an ultrasound or we have a CAT scan, why do we need to do a cystoscopy also? And the best answer, the best explanation is like we spoke to earlier, that bladder is like a big empty sac that holds urine. And a CAT scan and ultrasound give us good pictures of the outside, but we really can't see the inner lining of the bladder very well on a CAT scan, and especially not on an ultrasound. And the idea of maybe missing something or not being able to visualize something that could be important in a diagnosis makes just looking inside the bladder very important. We talk about cystoscopy. I get a lot of raised eyebrows, and people get more. I think the thought of it is probably more frightening than the actual procedure. Placing a scope inside the bladder, similar to having a catheter, it usually takes 3 to 5 minutes, if even that long. We pass the scope. There's a screen that we have next to us that you can look inside the bladder, and we can show you what we're looking at inside, what we're seeing, and it's usually over before you know it. Relatively in and out and done, you drive yourself there and able to drive yourself right back home again. Urinalysis, I apologize for the typo there, I didn't see that before. But a urinalysis, we just check the urine, and what we're looking for is there blood in the urine? Are there nitrites, which are split products from bacteria? We're looking for leukoestrase, which is a split product of white blood cells. So the idea is there anything that we could see in the urine that's indicative of infection? Anything indicative of any kind of bleeding, anything indicative of inflammation. Again, all looking to different causes for maybe why you're experiencing the symptomatology or the urinary symptoms that you're having. Something else that we do quite often is called a post-void residual or a post-void residual volume. And basically what that is a little handheld ultrasound. And after urination, we do an ultrasound on that bladder to say, okay, you finished urinating. Are you urinating effectively? Are you having a large volume of urine that retains in the bladder after you think you're done urinating? Our usual cutoff is about 200 to 300 milliliters. So after urination, less than 200 is good, less than 100 is better. And again, we're just making sure that that bladder is functioning okay. And all of the above here are minimally invasive, all done under local, no need for anesthesia. There's no cutting. We use all the natural openings, and they're tolerated relatively well. Another tool that we have in our urology toolbox is a bladder diary. And basically, the bladder diary is to help quantify, help us understand what exactly are your symptoms like. When are you voiding? How often are you voiding? Are you leaking? What is the severity of the leaking? And sometimes we keep a bladder diary, and we keep for, say, anywhere from 2 to 3 days. And we look across those days and just see how often those events are happening, when are they happening, and then we get a better idea of exactly what's going on, and have a bigger picture of exactly what's going on with you to come up with a solution. So speaking of solutions for individual people, we have multiple personalized treatment plan options. We'll start with the least costly, least invasive, and then we can work our way up. Number one on the list always is lifestyle changes. We talk about hydration. I'm a big proponent of hydration. I encourage my patients at a minimum at least 64 ounces of water a day, or 8-ounce bottles. If you're a 16.9 ounce kind of regular water bottle person, the regular bottles that everyone sees, 4 of those a day are perfect. And the idea is, if we're not drinking enough water, that urine becomes concentrated. That concentrated urine will then burn and irritate the bladder. And sometimes that's the sole cause of the overactive bladder symptoms. So just lots of hydration works nicely for people. There's also oral medication to help relax and minimize those bladder systems. There's the testing, like we spoke about earlier, and there's different procedures we could use, such as sacral nerve stimulation, posterior tibial nerve stimulation, and Botox procedures, all to relax the bladder and inhibit those feelings of urgency, frequency, and pressure. So we have here our basic pathway to bladder control. So looking at this pathway, we start out with our initial evaluation on the left in the light green. We talked about the voiding diary and behavioral modifications. So the idea is that initial evaluation, that's your first visit to the office. We're coming to meet for the first time. You're having either overactive bladder symptoms, you're having leakage, urgency, loss of urine with coughing, laughing, sneezing, or maybe not able to urinate well at all. So initial evaluation, we do our voiding diary. I'll likely get a bladder scan just to get an idea of what your bladder volume is, what your residuals look like. And we talk about lifestyle changes. I talk about maybe voiding every 2 to 3 hours. Even if you don't feel the need to urinate, every 2 to 3 hours, you just practice emptying your bladder and get into that habit. We spoke about hydration. 64 ounces of water a day, as long as there's no food restriction, is probably the bare minimum we should have from an overactive bladder standpoint. For generalized kidney health and for prevention of kidney stones, 64 to 80 ounces of water. Water, milk, juice are wonderful. Coffee and tea, alcohol, not so much. They'd be in the negative category. Not that you can't have them, but they really won't count to your minimal fluid intake. Going back to our little evaluation here, we could talk about conservative treatments, the lifestyle changes, the hydration. We talked about the time voiding every 2 to 3 hours. There's pelvic floor exercises or Kegel exercises. And what they aim to do is build up the strength of those pelvic and bladder muscles to help you better control your urination and urinary function. We could also talk about oral medications. So different medications we can use to try to reduce your feelings of urgency, frequency, or maybe to help that stream and flow if that's what the issue is. So earlier this year, these guidelines changed a little bit. And now these third line treatments that we used to have to go through these different steps before we could get to them, we're able to actually offer this sacral neuromodulation, Botox, and PTNS, percutaneous tibial nerve stimulation, as a first line treatment. So this is a relatively new guideline that had come out and been adjusted. They realize a lot of people either have side effects with medications or insurance issues having medications covered, and we could go right to more of a treatment rather than a medication to kind of band-aid the issue. Let's just treat the problem and eliminate the problem entirely. So that was a nice advancement for us to be able to offer something a little bit more direct, a little bit more curative. So normally after the initial evaluation, if we're going to try oral medications, we're going to try these lifestyle changes, pelvic floor exercises, I usually like to give it a good 4 to 6 weeks. Let's make these changes. And usually what I'll tell my patients is I'll make an appointment in four to 6 weeks. In that time, if you've made these behavior changes, if your urination is better, if your symptomatology is better, if you feel a lot more comfortable with how your symptoms are, we could cancel the appointment and I'll see you back in 6 months. If you do try these changes and you feel that either they're not working at all or not sufficient enough and things are still unhappy for you, then we could change gears and look at other options to get you to spend less time in the bathroom and more time doing things that we want to be doing. There's always a second line medication that we can try. If that second line medication is not something people are interested in, then we could talk about that cystoscopy and urodynamics depending on what your symptoms are. Or then we can move into these previously known as third line treatment options, but we can look at them as well. And we'll speak about them in the next upcoming couple of slides. I just think the takeaway point to this slide is there's a multitude of different ways to get where we want to go. And I think it's just very much on a personal basis, how anxious people are or how bothersome these symptoms are, how aggressive we want to be treating them from the get-go. But there's multiple different ways that we could try to attack this problem. There's multiple different ways to get you back to feeling like a happy young person again. It's just a matter of being patient, but we could find a way, and we will definitely do our best to get you back to being less time in the bathroom, more time out and about. So overactive bladder treatment, lifestyle. So lifestyle changes like I touched on before, hydration, 64 ounces of water a day. You want to dilute out that urine. I find a lot of people with overactive bladder, the more frequency urgency, the less and less fluid they drink. And it makes sense, right? I'm peeing all the time. I have urgency, I have frequency. I'm going to really reduce and cut down the amount of fluid I'm drinking. So I have less issues and less symptoms. Unfortunately, it works completely the opposite direction. Thinking about things, if we allow ourselves to get dehydrated, if we cut down our fluids because we don't want to urinate so much because we want to minimize those symptoms, when the kidneys then make urine, that urine becomes so concentrated. When that concentrated urine reaches the bladder becomes even more irritated, more burning, more discomfort, and oddly more severity of symptoms. So I tell people the solution to pollution is dilution. Gotta drink water. We have to dilute out that urine, let that bladder cool off, let that bladder be a little bit happier. Diet changes too. There's some people bladders are sensitive to acidic foods such as tomatoes, orange juice, spicy foods, garlic, onions, peppers could also cause mild irritation in the bladder. Caffeine, I'm guilty of it as well. Caffeine irritates the bladder, can mimic the symptoms of a urinary tract infection, cause urgency, frequency. I notice myself, if I drink that second or third cup of coffee, I'm running to the bathroom every 20, 25 minutes in the middle of office. You can have the coffee, but the bladder's going to give you the big old NO and say, you're going to drink this, you're going to pay for it. And I have some patients that could drink a cup of espresso at 10 o'clock at night and go to bed and do fine. It's just all how your body responds. My body gives it a big old no. Weight management, obesity, having extra weight around the belly, extra pressure on the belly is pushing on that bladder. And that can cause symptoms of urgency, frequency too. Just that physical weight pushing on the bladder, you always have symptoms of needing to urinate. Bladder retraining, like we talked about, getting your bladder into that habit and knowing, hey, you know what, every 2 hours, I'm going to urinate. Even if I don't feel the need to go, I'm going to take myself to the bathroom. I'm going to empty my bladder, and the bladder will eventually learn and adjust to going that often, and hopefully minimize your feelings of urgency. Pelvic floor strengthening, Kegel exercises. There's actually local physical therapy offices here that specialize in pelvic floor strengthening and training, depending on the degree of your issues and leakage. It can provide definitely help strengthening and controlling those muscles. Next treatment we'll talk about is medication, which I'm sure we're all too familiar with. I feel the older we get, the more and more medications we seem to be put on. And I know a lot of people, myself included, prefer to be on as few medications as we really have to be. But the purpose of medications from an overactive bladder standpoint, and just to clarify, so for overactive bladder, the frequency, urgency, there's certainly medications we can use to help alleviate, if not completely abate, those symptoms. From a stress, urge incontinence, a coughing, laughing, sneezing, there's really no medications we can use. So these medications, excuse me, are all more for overactive bladder, the frequency, urgency. And their goal is to relax that bladder muscle, that detrusor muscle, so you can physically hold more urine without feeling that urge and need to urinate. So our goal is fewer trips to the bathroom, fewer episodes of urgency. Medications usually taken up 1 to 3 times a day. I think the older generation medications were 3 times a day. Most of our medications are now just once a day. And it takes sometimes up to 4 to 6 weeks for that medication levels to become therapeutic, and for you to really notice and appreciate the efficacy and the benefit of these medications. There's two main categories of these medications. The first, and probably most common and the cheapest, are the anticholinergics, such as oxybutynin, Vesicare, Detrol, Ditropan. And these are all medications that probably came out from the 80s on, and we all, a lot of people have been on them. Studies came out probably in the around 2014, 2013, and they found that in the 60-year-old and plus crowd, these medications could cause cognitive changes, dry mouth, dry eyes, constipation, and just a slew of side effects. So personally, I just try to avoid them in my 60+ crowd. I think life has enough challenges, and taking a medication that can potentially cause confusion, can minimize our sharpness and cause cognitive decline. I don't need any more challenges in life than I already have. So I try to avoid those at all cost. But the silver lining is there is a newer kind of medication, a newer brand that came out maybe, I say within the last 4 to 5 years. Two medications that are like Myrbetriq and Gemtesa. Myrbetriq actually just went generic recently, which is a big sigh of relief because it's a lot easier to get coverage and a lot more affordable. And these medications do not have that same side effect as the medications we were originally talking about. And they also work in the same way. They help relax that bladder muscle so you can physically hold more urine without having that urgency and need to run to the bathroom. But the nice thing is that side effect profile is minimal, if almost non-existent. With the Myrbetriq, there's always a slight chance of elevation in blood pressure. And the Gemtesa in general really has no side effect profile at all. So it just works very nicely, and people seem to do well. An office treatment that we can provide that's usually done by our nursing staff or our medical staff is posterior tibial nerve stimulation, or PTNS. And basically the idea of this is there's an office procedure we do that takes about 30 minutes per visit. And you go once a week for about 6 to 12 weeks, depending on your results. And the idea is we place this little device on your posterior tibial nerve on down towards your ankle and foot, and it helps interrupt the signaling pathway between the bladder and the brain, so the bladder is not receiving that sensation of needing to urinate and feelings of pressure. So it just interrupts that cycle, and interrupts that missignaling, and tries to provide relief from that perspective. I mean, results I've seen somewhere in the 40 to 60% range. It's less invasive. It's outpatient. I just feel like the efficacy isn't always as good as other options that we have available. Botox injection. A lot of times we think Botox, we think wrinkles, we think crow's feet. This is Botox for the bladder, and it works on a similar principle. The idea of Botox is it paralyzes and relaxes that muscle so that scrunched up wrinkle becomes nice and flat and soft. Same thing with the bladder. So we put those Botox injections into that bladder muscle, and it allows that bladder muscle to just relax and not be as spastic. And by not being as spastic, you're not having that squeezing, you're not having the contractions, you're not having that constant urgency frequency to urinate. It's injected directly into the bladder muscle. It's done, I do it under a twilight or a lighter anesthesia. I do a total of anywhere from 10 to 20 injections across the bladder. Takes about 10, 15 minutes to do. Within usually 2 to 3 days, people have some benefits. Some people take up to a month for the Botox to fully kick in. Um, so it's just like a partial paralyzation of that bladder or that detrusor muscle. The main caveat, the main side effect we worry about is if we over paralyze that bladder muscle, then that bladder becomes big and flaccid. That muscle can't squeeze, then we can't urinate at all. So we go from having urgency, frequency, and overactive bladder to a bladder that's just kind of floppy and not squeezing. So there's a fine line between relaxing and over relaxing. Yeah, I find some people respond very nicely to this, and other people really have no response at all. I think another downside to the Botox is it lasts anywhere from 3 to 6 months, I think is pretty realistic, and then has to be reapplied. Um, just because the Botox works once, it doesn't always guarantee it's going to work again the subsequent time. So I've gotten kind of mixed results with this, but it's a less invasive first line if that's something people are interested in. Just the understanding that it needs multiple applications because it's not a permanent fix. Even when the Botox is placed, the goal is to still be able to urinate on your own and pass your urine volitionally. Sacral nerve stimulation is something that I just became really interested in probably the last 6 months. At my prior job, I had partners that had done this. I just never really saw good results, and I was just not very interested. Having come down to Oxford and learning new techniques and new ways to do this, I've become a very big proponent and a very big advocate of sacral nerve stimulation. The idea behind this is similar to like a pacemaker for your heart. And what is it's a pacemaker for the bladder. So if your bladder is overactive, urgency, frequency, having nocturia, we put a small little lead in the sacrum, which is down at the bottom of in between your hips and your center lower back. We put a small wire in there, and that wire actually interrupts the signal from the brain to the bladder and helps that bladder relax, almost filters out the noise, if you will, filters out those signals of telling the bladder that you have to pee all the time, or filters out those signals, creating that urgency. And the idea is to reduce your frequency urgency by at least 50%. And what we do is we do a diagnostic test in surgery. We go and do this diagnostic test. We put a temporary lead or a temporary wire in for 2 to 3 days, and you wear an external belt that has that pacemaker. And the idea is to really quell down or reduce down that urgency frequency. Once it's installed, it works right away. There's no delay. There's no waiting. After 2 to 3 days, we look at your voiding diaries. We'll sit and talk and see if your symptoms truly are better. If they are better, then we move forward to the phase two, which is the placement of a permanent pacemaker or a permanent implantable device, which is about the size maybe of a half a deck of cards, which goes underneath your skin and your lower buttock. Um, After this is placed, everything is internal, everything is below the skin. There's nothing to be seen on the outside. You're free to wear a bathing suit, wear a bikini. No one will see anything. All they'll see is you not using the bathroom as much. So it's a win all around. It's a small little incision, maybe 3 to 4 centimeters. Everything's, like I said, placed under the skin. And the battery life is anywhere from 12 to 18 years, depending on how much energy you use based on your symptoms. And that battery can always be changed when need be. Like we said, it helps calm the nerve that control that bladder function. It's also MRI safe, which is huge. I know as of late, a big issue has become MRI compatibility. A lot of people getting MRIs for different things, and this is MRI compatible. So that's one less thing that we need to worry about. I've had great experience with this, and I've definitely become a huge advocate for sacral neural stimulation. I've been in practice. I finished my residency back in 2011. And this is one of the few things in the last couple of years that I really picked up and have completely changed my point of view on. And I've just really seen such wonderful things come of this. So it's at least worth looking into. Stress incontinence, to kind of wrap things up, we didn't talk much about stress incontinence. Unfortunately, from a medication perspective, there's really not a lot we could offer for stress incontinence. We had touched on those Kegels and those pelvic floor muscle strengthening. If there's mild stress incontinence, perhaps the Kegels can help a bit. It's really been my experience, though. There's just no amount of Kegels one can really do to completely eliminate stress incontinence if it's truly present. Pelvic floor physical therapy can help minimize, but again, I just don't know that it would completely eliminate the leakage. There's a procedure that we offer in Oxford called Bulkamed. And basically what Bulkamid is the injection of a hyaluronic acid or a body equivocal fluid. And what we do is actually bulk up that opening to the urethra, the tube that you pass your urine from. When that muscle squeezes, the sphincter closes nice and tight so the urine doesn't leak. Sometimes over time, that muscle becomes a little bit lax and doesn't squeeze as tightly as it should, almost like a slow leak from a car tire. So what we do is we go in around where that muscle is and we bulk up that muscle and we help that tissue close and seal nicely. This way, with coughing, laughing, sneezing, there's no involuntary loss of urine. This, like the sacral neural stimulation, there's no wait time. Once that's the Bulkamid is put in, you're dry immediately. The literature, the research goes out about 7 years with efficacy wise, and we'll have to keep an eye on things and see how well this does. If people do leak after the Bulkamid, there's always the option, the ability to go back in and just do a touch up and just put a little bit more in if need be. Also, there's a similar product that we use for people with fecal incontinence that works on that same principle. If that sphincter is not nice and sealed tight, there's a little bit of leakage, we'll go in and just tidy up and kind of bulk up and help all that tissue close up nicely, create a nice tight seal. So there's no loss of urine or feces. Two different procedures, but similar in principle. There's also slings that we've been doing for many years. Slings have been around probably longer than I've been alive. And there's a placement of either mesh or sometimes we harvest some of the body tissue, body fascia, in order to support the urethra and minimize that leakage and the stress incontinence. Again, going in order of less to more invasive, you have the Kegels, the pelvic floor, and then the bulking, and then the slings would be last on the list. I see we have a couple of questions. I will head up and we'll go through these questions one by one. I'll do my best to answer them thoroughly and completely for you, with the understanding that if there's further questions, if you want to make an appointment, I'd always be more than happy to sit and talk with you and answer personal questions, individual questions. But let's give this a go and see what questions are out there. And again, I really appreciate all of you taking the time out of your evening and your dinner to at least attend this and educate yourselves about overactive bladder and stress incontinence. On the slide here, we have our office information. I have a QR code that if you just flick on your phone and put your camera on and focus the camera over that QR code, you can tap the little yellow hyperlink that pops up, and that will enable you to request an appointment if you want to talk to you further about any of these topics. Let's head over to the questions and see what's going on and see what everyone's thinking out there. All right, question number one. My husband is dealing with leakage, especially at night. He has low sodium and has been told to limit his water intake. Hearing that hydration is important, please share your thoughts. Depending on the degree of low sodium, which is also known as hyponatremia, it would always be best to either talk with your nephrologist or cardiologist or whoever has him on this fluid restriction. And like I said earlier, for the general population with no fluid restriction, 64 to 80 ounces is certainly would be my goal. If for different reasons he has low sodium, the concern is by drinking too much fluid, that might further dilute out his sodium and drop his levels even further, which could be dangerous. So I would advise whoever has him on that low sodium or that limited fluid intake, just ask how much fluid can he drink in a 24-hour period. So something like this, and it was a good question to ask, if there is a restriction for different reasons, it's always best to inquire what those parameters look like specifically for him because of the restriction that he has. But good question, thank you. How does an enlarged prostate affect bladder capacity? Well, enlarged prostate itself doesn't necessarily affect bladder capacity. The best way I could have you think about this, I don't know how well the hand visuals will work, but you picture the bladder like a big ball, and then the prostate sits right in front of the bladder like this, right? So you have a nice channel. When that prostate grows, the urethra passes through the center of the prostate. As that prostate grows, the prostate kind of shrinks down that tube, and that tube gets more and more narrow. Depending on how that growth is, it blocks the passage of urine from the bladder through the prostate. As that passage gets blocked, sometimes urine can back up and it can force that bladder to retain more urine because it's not able to evacuate as easily. That could cause increased bladder capacity, and over time, depending on the degree of blockage, could definitely lead to some serious issues. You notice a weaker stream, dribbling, multiple trips to the bathroom, just not feelings of complete emptying. So it can certainly lead to urinary issues, emptying issues, and a variety of other things. So if the urination is changing, if the urination feels weak, if it feels not as strong, it's certainly worth looking into and just making sure that you're emptying okay. Thank you for the question, though. All right, if I have a cage and two rods at L4, L5, can you have a sacral nerve stem? And the answer is yes. The sacral nerve stem is down in the sacrum, which is below your L5. So your L4, L5, that's your lumbar spine. Below the lumbar spine is where the sacrum sits. Where we do our procedure, where we do our sacral nerve stimulation, is in the S3 foramen. So definitely at the lower end, more distal from where your cage would be. And there should be no crossover, no interaction. All of the wiring, everything that we do is well below that cage. There should be no crossover, no interference. So that should be perfectly okay. Usually what we do if there's any concerns, we always reach out either to your spine surgeon or to your orthopedic surgeon and just get their blessing if there's any concerns. But we're in a completely different area of the pelvis, and there should be no crossover. Next question is, does Bulkamid require an invasive procedure? Bulkamid is not invasive in the sense that we use the natural openings, the natural orifice. And what we do is, like we mentioned earlier, we do like a twilight anesthesia, as we have to do 4 injections. I think it would be just for the idea of comfort. We put you to sleep, and we use a camera called a cystoscope, and we look inside that urethra, we look inside that bladder, and we do those 4 injections to bulk up that tissue to help maintain your dryness, help minimize leakage. It's four small injections, so not really invasive, no cutting, no suturing, no catheter afterwards. It's pretty much takes all of 10 minutes in and out. If for some reason there's difficulty with urination after the procedure, we leave it a tiny catheter just overnight, and that comes out the following morning. So in the grand scheme of things, I say relatively non-invasive. I think I heard you say that 2 or 3 times a night is normal. In general, getting up to urinate 2 to 3 times a night is 2 or 3 times a night at maximum. There's some people that sleep through the night, and God bless them. I probably haven't slept through the night since I was about 23, which is sadly more than a year ago. But twice a night on average. I usually tell people if getting up at night is problematic, if you don't want to get up as often at night, about 3 hours before bed, it's always wise and prudent to restrict your fluid intake. And drinking less water at night, this helps with the getting up at night and helps with the nighttime urination. So not getting up at all at night is perfectly fine. Usually I set my cutoff at about 2, maybe 3 times a night. People getting up more than that, I tend to more push them to look at the different things that we could do to try to minimize that, because it just becomes so disruptive. I think it's just hard to get a good night's sleep if you're running back and forth to the potty. Okay, next question. Is Bulkamid for men/stress? Bulkamid can be used for men, men that have had prostate cancer or men that have had their prostate removed. Sometimes are more prone or definitely more prone to stress incontinence. Depending on the severity of the degree of incontinence, there's different bulking procedures that we could do for men who've had prostatectomies or prostates removed as well. Next question, any issue with long-term Cialis? Cialis in general for, just to rewind a bit, so that's more into the realm of erectile dysfunction. Cialis is used to help bolster erections and help have more stronger rigid erections. I don't know of any long-term issues per se, as long as from a cardiac perspective, you have no problems, nothing's going on. I don't know of any long-term concerns or issues with using Cialis, as long as it's used as prescribed and as was intended to be. We have a question about TURP procedure. TURP is the initials for a procedure called transurethral resection of prostate. So for our young men out there with enlarged prostates that are obstructing or blocking urinary flow, we go in with a scope again under anesthesia, but we go in with a scope and literally shave out or carve out a nice tunnel, a nice opening to allow for the better flow of urine. Like I tried to show with my hands earlier, and I think I failed miserably, so I apologize. But shaving out that prostate, creating that tunnel, allows that bladder to empty with more ease and has less restriction. So picture trying to push water through a small straw versus a big garden hose. You want that nice big wide opening to allow better flow of urine, less effort, and less time back and forth in the bathroom. There's a TURP procedure we do. There's also minimally invasive procedures such as Resume, Urolift. There's green light laser, and there's the tried and true TURP, all meant to treat varying degrees of prostatic obstruction or bladder outlet obstruction. I have a form of muscular dystrophy. How would this affect any of the treatments mentioned? It would really depend on what your symptomatology is. What kind of symptoms are you having? What is your overall function? If you're having overactive bladder, spastic bladder, I think the sacral neuromodulation could certainly be beneficial and helpful if the bladder is overactive. If you're having pressure, squeezing, uncontrolled leakage, urgency, helping to interrupt and disrupt that muscular pattern, we can always do diagnostic testing and just see how you respond individually. Just as of late, I've had young men and women with Parkinson's and Alzheimer's with tremors, shaking, and whatnot, and also with really difficult overactive bladder symptoms, and they've responded really beautifully to the sacral neuromodulation. How can you enlarge bladder capacity? Bladder capacity, the bladder is pretty elastic. A comparison for the bladder I also use is sometimes like an athletic sock or an elastic sock. The bladder itself is pretty elastic. It kind of stretches and contracts pretty forgivingly. So I don't know that enlarging the bladder capacity is really necessary unless the bladder is contracted or shrunken for some reason. But your average bladder capacity, like I said, usually around 500, you kind of get that like, I got to go and I got to go now. But in general, the bladder could probably hold a liter plus if it really needed to. The concern is like anything else, if you overstretch out an athletic sock, you overstretch out an elastic, eventually it becomes big and floppy and it just doesn't retain its turgor. It doesn't retain its shape, and then the bladder tends to lose function. That detrusor muscle gets overstretched out, and then it just loses its ability to contract, and then we're in a pickle. Nothing against pickles. Rename the food or fruits that cause overactive bladder. So basically what we had mentioned on before was there's different foods that are acidic such as like grapefruit juice, grapefruits, oranges, tomatoes, anything that's very acidy, anything, think acid reflux, anything that would cause that's acidy to ingest, when it's processed through and excreted through the bladder, it could sometimes create urgency, frequency, and different kind of overactive bladder symptoms. So people with sensitive bladders, I tell them to avoid spicy foods, peppers, onions, garlic, things like this. Szechuan, alcohol could sometimes be really irritating to the bladder lining. Tobacco and spicy food. That's the basic generalized realm. But usually I tell people whatever would normally cause you acid reflux and whatnot, that same kind of acid burning it can be transmitted to the bladder also, and can sometimes potentiate your overactive bladder symptoms and issues. If there's no other questions, I guess we can kind of wrap things up. I realize I've been chatting here for almost an hour. I didn't realize how long it's been. But like I said, I just want to say thank you again for everyone taking their time out of their busy day or early evenings to spend with us. I hope my answers to your questions and at least my PowerPoint discussion was at least a little bit educational and maybe inspirational if you've been suffering in silence and suffering with frequency, urgency, or leakage. Just know that there's things that we could do to restore you back to a normal, happy life again. And you could go out and be doing things, not worry about pads and pull-ups and leakage and change of clothes or scoping out every bathroom within a 5-block radius of where you are. But otherwise, I want to thank you again. My name is John Lynam. We have offices in Leesburg and Oxford, and in my practice in general, we treat a whole variety, almost fully encompassing all aspects of adult urology, male, female, oncology, cancer work, overactive bladder, men's health, women's health. And we're always happy to see and accept new patients, and always happy to take time and answer questions. I hope you all have a good evening, and I appreciate you all for attending. Thank you.